we're going to now hear from our genetic counselor, Katie Agri from the Mayo Clinic. Katie's been with us before, and we really appreciate her taking the time away from her new mommy duties. So take it away, Katie.
Thank you so much. It's always a pleasure to work with you, Muriel, and the rest of the amyloidosis support group. So I'm excited to talk to you all a little bit today about genetics and genetic counseling for transthyretin amyloidosis. I am a genetic counselor. I'm going to talk a little bit more to what that means. So I'm going to first just by describing, what actually is my job. So as a genetic counselor, genetic counselors have specialized education in genetics and counseling. There's more than 5,000 genetic counselors across the nation, and there are different specialties that genetic counselors can focus in. So I focus primarily on cardiology and have a particular interest in amyloidosis, but there are genetic counselors who specifically focus in prenatal or cancer or pediatrics. I think what's important to know as a patient or a family member of someone with transthyretin amyloidosis is that you probably want to seek out a genetic counselor who has some experience with this condition, and those counselors primarily may focus in cardiac disease or neurology. Genetic counselors do also help with the genetic testing that some of you may or may not have had, and writing those reports and making sure they're all correct and accurate. So get into why would you actually see a genetic counselor for hereditary amyloidosis? I think the obvious answer that comes to my head, as well as many others, is to undergo genetic testing, and that is absolutely true. I think an important component of that is a genetic counselor can really help one understand the risks and benefits of undergoing genetic testing, because there are a plethora of both. In addition to this, genetic counselors can go and help with other aspects of your care. They can help you understand the genetics and inheritance of this condition. Reviewing family history, which can be really important for identifying at-risk family members, and then also understanding how has this condition been passed through your family in generations previously, and how is it manifested in other relatives, which can give us clues to what should we monitor for you and your loved ones. Of course, in some families, we don't have a great picture or great idea of where this is coming from, but regardless, it's always important to look back at your family if it's possible. Genetic counselors can also help with the discussion of family testing and give ideas about communication, and I will go into that a little bit more later on in my talk today. So a little bit more on how should you share this information with your loved ones, and then how and when to talk to children about this condition. While it is not a childhood onset disorder, it is something that is important to make sure there's open communication if at all possible. And then finally, resources and support. And the biggest resource I give to my patients is talking about the amyloidosis support groups. So before we get into any more of that, I'm going to just kind of lay out the basics of genetics, first of all, and then really going into the genetics of transthyretin amyloidosis. So some of this might be review, but what I explain to every patient who walks in the room with me is your body is made up of billions of cells. You have heart cells, stomach cells, liver cells. In each cell is where your genetic material is contained. It's contained in chromosomes. I'm not going to be using that term a whole lot, but your genetic material or your DNA is unique to you. You get half of your genetic material from your mother, and you get half of your genetic material from your father. And that genetic material is broken down into genes. Again, you have two of each. Each gene has a particular function in your body, whether it's making your eyes a certain color, determining how tall you're going to grow, stopping certain cancers from growing. But again, you have two copies of each gene. Going a little bit further into that, we know a gene is an instruction to create a protein in your body. So I give the example about eye color. There's particular genes that if they're spelled a certain way, they're going to create a protein that results in someone having blue eyes. If there's a genetic change, and not a bad thing whatsoever, but if there's a genetic change within that gene, it's going to create a somewhat different protein, and that protein might result in someone having brown eyes. We all have genetic variations. It's what makes us all unique and individuals compared to one another, but we know that sometimes genetic changes can actually cause a genetic condition. So when we're talking about transthyretin amyloidosis, we're talking about the gene called TTR. Again, everyone has 2 copies of this gene, and it's whether or not that gene is working the proper way that determines whether or not someone could be at risk for this condition. What's really important, as many of you already may know, is that different changes within the gene can have different names. So I'm going to elaborate into that a little bit more here. Different lettering systems you might see if you've ever had a genetic testing report. So one of the first changes that you'll notice is this C dot number. This particular numbering is referring to the particular DNA change that's in your family. So what this means is that in the transthyretin or TTR gene, if you count 424 letters into that gene, typically people have the letter G at that position. But some people will have the letter A, and that's associated with an increased risk for developing amyloidosis. What is also important is that particular DNA change also results in a protein level change. And so the other kind of lettering you might see is this P dot. P stands for protein, so that's going to be the easiest way to remember that. And in this situation, at the protein level, at the 142nd position, there's typically this protein called valine. And what happens because of this DNA change is that valine is shifted to a different protein called isoleucine. There are 20 different proteins or amino acids that can shift. But this particular combination, when we see this DNA change and this protein change, can cause specifically, usually cardiac amyloidosis. I think the other piece that's important to know, and you probably have heard this term a little bit before, where we call things, Val 142 isoleucine and then sometimes Val 122 isoleucine, is that there was a change in how we classified these protein changes. So if you think about the TTR protein, it's actually about 147 proteins long. The first 20 of those proteins are actually cut off. And we used to count those when we were talking about the naming system. And so that's why what we used to call valine 122 isoleucine, now that we count those 20 again, we're just adding 20 to it. So when we're talking about Val 142 isoleucine, we used to call it Val 122 isoleucine. When we're talking about Val 50 met, Val 30 met. So there's that kind of system. And so if you're seeing that 20 letters off when you're talking about the genetic change in your family, know that it's just 2 different ways of saying it, but we're doing the one that includes that 20 amino acid region that used to be cut off, but it can be a little bit of a confusing point. So anyway, there are many different genetic changes that have been reported within the TTR gene. Again, the important thing to know is which is the one that is in your family. What is the particular number on the DNA level, which is that C dot, and what is the particular numbering on the protein level, which is that P dot. Why is that actually important? Why do we care about which number it is or where it is within the gene? We know that there are correlations, so that particular genetic changes tend to present with different types of symptoms. So I gave that example already of that P dot Val 142 isoleucine primarily causes cardiac amyloidosis. A different genetic change, Val 50 met, tends to present with peripheral and autonomic neuropathy. And then tyrosine 89 histidine tends to present with more central nervous system concerns and vitreous opacities of the eyes. I think what's really important to remember, though, is that this is a trend. It's not a rule. It doesn't mean that something else won't develop for you or your loved ones. And that's where it is also important to look back at your family history and say, what have other people presented with, so that we can better understand what do we need to watch for in you or your other family members. So going a little bit further, I mentioned already, everyone has 2 copies of the transthyretin or TTR gene. And this particular condition follows an autosomal dominant inheritance pattern. That's really just a fancy way for saying it takes one genetic change on one of your 2 copies of the gene in order to be at risk for symptoms of this condition. This is also a condition. Autosomal just means that both men and women carry this particular gene and can be at risk for the manifestations of this condition. It's not just men, it's not just women. So an important thing about meeting with the genetic counselor and what I'll do with all of my patients is review their family history. And so in this example, a gentleman comes in with a diagnosis of cardiomyopathy, he has carpal tunnel syndrome, and he has peripheral neuropathy, and he was recently told he has a new diagnosis of TTR amyloidosis. We know that this is genetic because of genetic testing. And so he asked that question, okay, so what does this actually mean for my family? And I think a lot of the questions that I get as a genetic counselor are, okay, I have 3 kids or I have 5 kids. What does this mean for them? And that's a really important question. We also need to acknowledge that other people in the family are also at risk. And so again, having a newborn, or I guess not a newborn, 8-month-old at this point in time, I totally understand children are kind of the first, line of what you're thinking about. But we also need to think about that siblings have a 50% chance of also having this condition. It usually is coming from one parent or the other. So if we're thinking about it going back, I'm going to skip forward here. If it's coming from one parent, it could be in aunts and uncles, it could be in cousins' children, first cousins, second cousins, keep on going. And so there are a lot more people to think about besides, one's children. And I think what's also really important to understand is we don't always see a pattern in the family. So this condition is very much a variable condition, and this is true even within the same family, that we'll often see different ages of onset. We'll see differences in the severity of symptoms that one has. We'll see differences in the types of symptoms. So I have patients where their brother has cardiomyopathy and they just have peripheral neuropathy. And so we'll see those types of differences as well. And then I think importantly, as many of our presenters have said already today, some people will be asymptomatic throughout their whole lives. There's a lot we still need to understand about why some people will present so severely and sometimes at such a young age, and why some people, maybe their sibling, maybe their child, maybe their parent won't ever present with this condition. So we still have a lot more to learn about that. So genetic testing. So why do we actually do it? Why is it important? Of course, we need to confirm whether the amyloidosis is that hereditary versus the wild type. That's important not only from a treatment perspective, but also it is necessary for testing family members. If it's the wild type form and you or your loved one, at this point in time, we wouldn't think that your risk is any higher than an average person for developing wild type amyloidosis. If it's hereditary, we know it's a 50% chance based on how it's passed down in the family. And again, going back to what particular genetic change we find in an individual and their family can provide us information about what do we expect medically. So then going on, so discussion of family testing and communication. So in this situation, dad's kind of thinking, should I actually share this information with my family? If I should, how should I go about doing that? So I definitely advocate for sharing this with information with your family members, especially now with the availability of different clinical trials and medications. This is information that can be really valuable for others. And so the best, I think, piece of advice I can give is try to have open communication if at all possible. What we'll often do as genetic counselors, and this is also available through the amyloidosis support groups, is provide a family letter. And if I skip forward here, you can see kind of an example. Basically, it's saying that a member of your family has been found to have this condition. It has that particular lettering of what is the DNA change and what is the protein change, and explaining what it is and what they can do about learning more about their risk. Always providing other resources. Sometimes it's hard to just start out Googling this condition and not knowing what's a reliable source and what's not. So direct them to the amyloidosis support group website. I often recommend also identifying who in your family is the communicator. Maybe you don't like talking about your health history, and that's okay. But if you know, hey, my sister, she has the genealogy going back, 5 generations, she's probably the good person to give this information to, because she might be in contact with that cousin that you haven't talked to in 5 years, or she might be willing to share this information with your sister who lives out, on a different side of the country. So. But finally, your family best, what kind of communication styles work best. So really rely on, your gut reactions of, what would be the best way to share this. If in person, I think that's ideal. With this pandemic situation, I think more people are sharing this virtually. So just doing whatever you think is best in your family. So I'm just going to go through this example here. So we know that dad has TTR amyloidosis. It is the hereditary form. One of his two genes is not working. So what I would share with dad is that means there's a 50% chance for each of your kids to also have this condition. So kids then often ask that question of, okay, I don't have symptoms. Should I be tested for this? And other people will say, no way, no how. I do not want to be tested for this. I am not even going to think about this. So know that both reactions are very normal. So why would people actually get tested in the first place? I think it's important to know that this is a personal choice. Again, oftentimes in the family, there are going to be people who feel very differently. But this can help some people make life choices about what type of lifestyle do they want to lead. So in some cases, it can inform reproductive decisions. For some people, it relieves their anxiety of uncertain. I certainly think that's true. If someone is negative, they don't need to worry about this anymore. But if it's positive, it's important to know that that uncertainty doesn't always go away, because we can't predict whether or not you're going to develop the signs and symptoms that your family members might have had. Knowing for the sake of children, I'll go into that a little bit more in a few minutes. I think this is a really important point, is allow for earlier diagnosis and clinical monitoring. If you are developing the signs or symptoms, we want to start treating you as early as possible. And again, as you know, talked about earlier, there's not a perfect pre-symptomatic treatment option available right now. But if you show any signs or symptoms of this, it's important. And sometimes you might not see that. It might be, you know, on a very subclinical level. It is still important to be connected with a good amyloid team. But again, genetic testing is not a crystal ball. It's great if it's negative, but if it's positive, it doesn't give us the clarity that sometimes people want. So in this situation, you know, someone might be thinking, okay, you know, maybe I am interested in genetic testing. So I think it's important to think through, how am I going to use this information? How will I actually react if I learn I'm positive for this condition? What will I feel if I'm not at risk? You know, what if all my siblings are at risk, but I'm not? Sometimes you have some guilt over that. Am I actually able to handle the impact of a positive result? It's kind of a stressful time for a lot of people right now. Is this the best time for doing it? One piece that I'll just mention, I won't go into a lot of detail about this, is some people have concerns about genetic discrimination. So there is a federal law called the Genetic Information Non-Discrimination Act of 2008 that protects most Americans from discrimination by their health insurance and employer if they learn they're at risk for this condition. The important thing to know about is this law is very, very much for people who are pre-symptomatic and have not manifested any signs or symptoms. That law generally does not apply to things like life insurance, disability insurance, and long-term care insurance. And so some people want to talk to a lawyer or financial advisor about that. Okay, so in this family, results come back. You know, positive result means, yes, we did identify that same mutation. It's important for someone to seek care with a medical team with experience in amyloidosis. And in this situation, Sarah came back positive, and her siblings came back negative, which means they did not inherit this mutation. No further evaluations are needed. One last thing I'm going to just end with here is, okay, then, you know, Sarah has children. She has a 16-year-old and a 4-year-old. Now what? Again, I mentioned this is not a childhood onset disorder. I do not recommend testing of children, you know, one, because of the concerns about genetic discrimination. I don't think any 16-year-old or younger, probably even older than that, is thinking about life insurance, but that can be an important piece of things. And also just making sure, you know, someone has the autonomy to make this decision for themselves, because it is a really personal decision, and someone may or may not want this information at this point. So should I share this with my children? And I'll kind of, you know, share some tips about this in the setting of, I have some people who say, I'm nervous about telling, you know, this information to my children. I don't want to stress them out any more than they have to be. I totally get that. But I do encourage, you know, sharing information with children, because again, usually children are a lot more perceptive than we're even thinking they are. They might pick up a lot more than we even think that they're getting. So we do recommend that minors should be informed about genetic risk, but this looks really different depending on the age of the child. What's really important is that parents should take time to process their own potential genetic risk before informing their children. So if you just got your genetic test result yesterday saying you have or are at risk for this condition, you don't need to go tell your children tomorrow. You can take weeks, days, months, whatever that looks like, to process it, because it's important to really understand what are your own feelings and emotions about this before taking that next step and sharing that with your children. From research, we have found out that parents should ideally be the ones to share this information with their children. So this shouldn't be something that, a letter is on the counter and the child happens to read that and learns about their risk that way. Or, at a family reunion, a cousin who they just met shares this information with them. We don't like that sort of thing. We want parents to be able to share that information ideally if possible. It's always better to start conversations sooner rather than later. So I have some people say, nope, I'm going to wait till they're 18 to share this information with them. And unfortunately, that can cause some resentment where children are, upset that they just learned about this now, when it would have been helpful to potentially kind of give that information in age-appropriate doses over time. So the conversation you'd have with a 4-year-old is going to look tremendously different than a conversation you'll have with a 16-year-old. But just thinking about what is the best way to do this in my family. It's important to be honest, but also to try to be hopeful and positive. And I think that is very much something that I encourage my patients to do, especially with all the treatment progressions we've had over the last few years. And then follow up with the genetic counselor if you think this would be helpful in your family, or if you're trying to figure out what is the best way to tackle this conversation in my family. That can be something a genetic counselor can help with as well. And then I'll just end on this last slide saying there are other reasons to talk to a genetic counselor. Sometimes we do have complicated genetic testing results. I think more often than previously, this gene is being identified on a larger panel where we might have other findings besides just the ATTR genetic change. So that would be a good reason to talk to a genetic counselor. If there are other conditions in the family, need for confirmatory testing, or if you've undergone genetic testing through something like 23andMe or Ancestry, or learned this as an incidental finding, that's another good reason to talk to a genetic counselor. But with that, I'll say thank you so much for having me again, and I'm happy to take questions either now or in the question and answer session.
Thank you so much, Katie. That was really helpful. And there will be questions later on, and there might be some in the Q&A section. I haven't looked there. And we appreciate all of your help, everyone. It's really been great, and all of you that are answering the questions on the Q&A as well.